Good morning, everyone. Welcome to today's Saturday clinical meeting. Today we'll be discussing a case of young girl who presented with generalized swelling, a common presentation. Now I request Major Ram to start.
My patient is a 16 years old female studying in 11th standard, resident of Pune, Maharashtra, informant being self, mother, and previous medical documents with a good reliability. She presented on 9 January 2025 with complaints of decreased urine output, passage of foamy urine, and early morning facial puffiness for 1 month duration. She was apparently asymptomatic 1 month back when she noticed reduced urine output, which was insidious in onset and gradually progressive. However, she was not able to quantify the volume. She also gives history of passage of foamy urine, which was insidious in onset, gradually progressive, and difficult to flush. There were no associated aggravating or relieving factors. She also had history of facial puffiness, which was noticed more in the morning and gradually reduced as the day progressed. It was associated with swelling of both her lower limbs and painless progressive abdominal distension. There was no history of fever, rash.
Wait, Ram. Vikrant, take the mic. What are we ruling out?
So in a patient presenting with
Swelling.
oliguria and swelling, sir.
Swelling and foamy urine.
And foamy urine, sir. Firstly, fever. We want to see for any infective causes, sir. Rash, joint pain, oral ulcer for connective tissue disorder, sir. Hematuria, we want to see hematuria. Basically, we have to rule out any stone disease, UTI, or nephritic syndrome. We have to see.
Nephritic syndrome.
Sir, lithuria, stone disease in the past, a past history of lithuria and stone disease. Again, we have to see for any kidney stone disease.
That can lead to some glomerular changes, which can.
Sir, breathlessness, orthopnea, PND, and chest pain, sir. We have to look for cardiac causes of swelling. Jaundice, hematemesis, and melena for chronic liver disease features, sir. Pain abdomen. Again, we have to pain abdomen, sir. So any like portal vein thrombosis
with foamy urine, diagnosis is very narrow,
sir.
So pain abdomen, vomiting, loose stools. We are trying to rule out the complications. That's it. First year, Harish, are you there? Causes of anasarca.
So causes of anasarca include either a cardiovascular cause, that is, then again cardiovascular because of cardiovascular causes include either a heart failures or then again in cases of nephrotic syndrome or nephritic syndrome, patient can have anasarca. Then again
more of nephrotic, less of nephritic.
Then again, in cases of chronic liver disease, patient
more common chronic kidney disease. You have seen so many patients.
Chronic kidney disease. Yes. Then chronic liver disease patients can also have anasarca. Then patient of hypoalbuminemia
because of malnutrition or other causes. Oliguria. Samir. She has not quantified, but she says gives history that it has decreased.
Oliguria can be defined as a urine output of less than 400 to 500 ml per 24 hour or 0.5 ml per kg per hour in 24 hour. And in children, 1 ml per kg per hour, sir.
Okay. What else? Why 500?
So 0.5 kg, 0.5 ml.
Why this figure of 400 or 500? This is stat question of SCMs. Because maximum osmolality that can be achieved in urine is 1200, and it has to excrete minimum of 600 milliosmoles. 600 divided by 1200 is 0.5, that is 500. Sit up. Causes of frothy urine, third year. Robin. Foamy urine can be present in a normal individual. When does it become significant?
Sir, when it is the foam is there or the bubbles are there in multiple layers and it is difficult to flush, sir.
Yes.
The causes can be proteinuria, amino acid urea, phospholipiduria, or even bile stasis, sir.
Proteinuria is common, phospholipid, bile stress. Okay, these are rare, very rare. Okay, sit down. Continue.
She initially presented in 2010 with complaints of facial puffiness, abdominal distension at 9 months of age. She was diagnosed as a case of nephrotic syndrome, for which she was started on oral steroids in December 2010, following which she was in remission. However, she had multiple relapses between the year 2011 to 2013, whenever she was tapered off steroids. She underwent renal biopsy in the year 2014, for which she has lost the reports. She was given 6 doses of injection cyclophosphamide in suspicion of steroid-resistant nephrotic syndrome in April of 2024. She was in remission in the year of 2016. Then she again had a relapse in the year 2017. She was started on oral steroids for the same. In the COVID-19 pandemic in 2019 to 2020, she was lost to follow-up. She again presented with relapse in the year 2020. She also gives history of consumption of homeopathic medication in the year 2024. And she again presented in relapse in January of 2025. She also gives history of multiple episodes of upper respiratory tract infections and acute infective diarrheal episodes while on steroids. This slide shows the number of relapses and the management given in a tabulated form, with history of receiving cyclophosphamide in the year 2014 and 2018. She also gives history of consumption of homeopathic medication in September of 2024 prior to the present admission. There is no history of similar complaints in family. She consumes a mixed diet. Her bowel and bladder habits are normal. She has a normal sleep pattern, and there is no history of blood transfusion in the past.
Dinesh, first year. Dinesh, summarize.
Sir, a 16-year-old girl presenting to the hospital with histories of frothy urine and in a known case of nephrotic syndrome in the past, having multiple relapses.
Okay, sit down. Ram, you continue.
She is a 16-year-old female, known case of nephrotic syndrome, minimal change disease, presented with complaints of anasarca, oliguria, and passage of frothy urine for 1 month duration, with significant history of multiple relapses in the past.
Akash, syndromes in nephrology. So any patient there are 10 syndromes given in Harrison.
So we have nephrotic syndrome, nephritic syndrome, AKI, RPRF, CKD.
RPRF, AKI is same.
Sir.
Okay.
CKD, sir. Then asymptomatic urinary abnormalities, obstructive disease, sir. Then UTIs.
Tubular defect.
And tubular defects, sir.
Okay.
Hypertension.
So out of these, this patient fits into what? Nephrotic is obvious.
She's
What else?
presenting into nephrotic syndrome, sir.
Hmm.
We don't have any evidence we don't have a renal function test. Otherwise, we don't know if it is CKD or not. And she can also fit into nephritic.
Nephritic. What are the features of nephritic?
Nephritic will present with hypertension, hematuria, non-nephrotic range proteinuria.
Okay,
sir.
but with history, one more you can make up.
AKI, sir. She is giving history of oliguria.
Oliguria. Okay, sit down. So, any pediatric, Kirti, major Kirti, pediatric. Nephrotic syndrome. How do you diagnose?
Sir, proteinuria of proteinuria 3 plus or 4 plus, 3 plus in urine, then serum albumin less than 3, and urine protein creatinine ratio of more than 2, and there is anasarca, history of edema, periorbital puffiness.
Anasarca, okay. What else?
Hypoalbuminemia, and there will be increase in the lipid profile, hypercholesterolemia.
And lipiduria also, which we usually don't check.
Yes.
Can you also tell the criteria for adults? No.
No,
Okay. Chalo. Veterinary for adults. How much protein?
Sir, it is 3.5 grams, more than 3.3 to 3.5 grams per day proteinuria. And
Per day per 1.73 meter
meter
square of body surface area. Size matters. Okay. And she told serum albumin less than 3. So different textbooks, it may be 3 or 3.5, but as per KDIGO guideline, it is 3.5. Okay. Sit down. What are the causes of nephrotic syndrome? Second year. Sudhindra.
Sir, it can be minimal change disease or
Primary cause, primary disorder. Minimal
primary
change.
sir, minimal change disease and focal segmental glomerulosclerosis
And
membranous glomerulopathy, sir. And
yes.
amyloidosis.
And rarely C3GN usually present like nephrotic. IgA may present like anything, but rarely they may also present like nephrotic syndrome. Secondary causes. Next.
Diabetes.
Continue.
Diabetes, sir.
Commonest. Rather, it is the commonest
And
cause
protein.
of nephrotic syndrome.
And protein losing enteropathy, sir. Any like multiple myeloma.
Commoner. Anyone? Vikrant. Next.
So SLE, Sjogren's,
Very
RA,
good.
preeclampsia in females, sir.
Malignancies.
Malignancy and
Infections like
hepatitis B infections.
hepatitis. What are the common causes of nephrotic syndrome in childhood, pediatric? Major Gaurav. Out of these primary causes, no, pediatric resident, you sit down.
The commonest cause is minimal change disease, around 80%, followed by focal segmental glomerulonephritis. Then MPGN in secondary causes infections, followed by, and also, sir, there are congenital nephrotic syndromes. In secondary infections, followed by autoimmune disorders, followed by drugs like penicillamine. These are the common causes in
They are rarer, but MCD is 80%, as you said correctly. Good. In adults, Abhishek?
Say in young adults, FSGS is more common, while in older adults, membranous nephropathy is more common. And MPGN can also present at older age, sir.
What is MPGN?
So membranoproliferative glomerulonephritis, sir.
How do you divide that?
So it has three three subdivisions, sir. Type 1, Type 2, Type 3. Type 2 is...
No, now it's 2.
So type 2 is dense body disease.
Two divisions. So immune complex and complement mediated.
Yes, sir.
So you said FSGS is more common. But what is found in whites, it's almost equal. Okay, FSGS. FSGS is commoner in African Americans as well as in India. Okay, sit down. In elderlies, it is membranous, and again number 2 is MCT. It makes a comeback. AKI definition, first year. Gaurav, now you stand. Medicine resident.
So, AKI, stage 1 AKI is defined as rise in serum creatinine 1.5 to 1.9 times in 24 hours, sir, or a reduced urine output, sir.
In 7 days, presuming that it was normal before. And absolute value of more than 0.3 in 48 hours. If you have reports available, like in hospital, AKI is very common. And what about urine output? Already discussed.
Less than 0.5 in
0.5 ml for 6 hours.
per hour.
For 6 hours. Okay, catheterized patient. Causes of AKI in nephrotic syndrome, Hemant. Nephrotic syndrome, AKI. There may be an overlap also of syndromes. No?
There could be pre-renal AKI, sir, or
pre-renal AKI.
Yes, sir.
Yes. Why? Because of intravascular volume has decreased extravasation.
There could be acute tubular necrosis because of
when it becomes severe. Okay.
Yes. And because it's a prothrombotic phenomenon, there could be renal vein thrombosis, sir. And any internal edema, sir. Response to any drugs given to patients like ACE inhibitors or ARBs or any NSAIDs.
Anything else?
Transformation of the disease, sir. Like